Good morning. I have the pleasure of introducing today's Grand Round speaker, who is one of our own. I first have the code, which is my favorite code we've ever had. It is SUPCOW, S-U-P cow, C-O-W. So SUPCOW for the code. Now to our speaker, Dr. Beninati. Of course, needs very little introduction. We all know him well, but Dr. Beninati came to us after residency at Baylor, MFM fellowship at Brown. He did his surgical critical care fellowship here at UW before he officially joined our MFM faculty. He serves a lot of really unique and super vital roles in our division and department, being our sort of collaborating force between our critically ill patients at UW and complex maternal care here at Meriter. And then a few years ago, he had the opportunity to get involved in fetal surgery, and he jumped right in, which I think was largely to do anything to not be in the outpatient clinic. But despite that as an excuse, he has fully launched himself into this program in the world of fetal surgery, doing really fantastic cases, research, national presentations, international presentations. And today he's going to give us a picture of fetal surgery. So welcome, Dr. Beninati.
Thank you very much. I'm going to start and end the talk on notes of gratitude, because the only reason that I get to stand up here and talk about any of this today is because of the work of literally hundreds, if not 1,000 people here at UW. So I'm going to say thank you now, and then I'm going to end by saying thank you as well. So taking a brief journey through fetal surgery in the past, and then present here at UW, and what we hope to look forward to in the future. I have nothing to disclose. Fetal surgery has really just taken off and run here at UW and in Madison. It's gained, a lot of, attention in the lay press. But before we could have nice articles about, these good outcomes for patients here at UW, and before we got to meet this, handsome couple of babies, we need to look back, to the, kind of founding patients of fetal surgery. So let's go back to a different intelligent couple, New Zealand, 1961. An article that's, old enough that you might need to look at it on the, like microfiche or whatever it's called. And, in the 60s in New Zealand and around the world, they were dealing with a rash of premature, hydropic, pale babies that were being stillborn or that were dying in the perinatal period. They kind of discovered hemolytic disease of the newborn, and they discovered amniocentesis to test bilirubin levels. But in spite of those advents, they were still noting a persistent perinatal mortality of about 8 to 10%. And so a group of physicians, had the idea, maybe there's something that we can do to help these fetuses. And so in view of this hopeless prognosis for one baby who was sent for referral to this center in Auckland, the perinatologist there counseled this very intelligent couple and said that, while we don't know if this, sort of procedure will necessarily help, we think that the prognosis is grim, and we're, willing to try. And so they grabbed their O negative blood and they grabbed their 3D ultrasound. Unfortunately, no 3D ultrasound in the 1960s. All they had to go by was x-rays. And so this is an actual x-ray from the case report. And they discussed how they gave the first intrauterine transfusion into a human. And so for the order of operation, they injected 20 milliliters of contrast blindly into the uterus. They took a fetal x-ray, not this one, but they took a different fetal x-ray that showed that the placenta was left anterior lateral and the fetal lie was vertex ROL, and there was no evidence of hydrops. I don't know how they knew most of that, but alas, that's what the x-ray showed. Then they waited 5 hours for the fetus to swallow the contrast. They took a repeat x-ray to show that they had done that. And then they aimed the needle into the peritoneal space. This was all, the aiming of the needle into the peritoneal space was all blind. They talk about, inserting the needle and feeling that it's in the abdominal wall based on the resistance, and then a give. And so they presume that they're in the baby's guts. And then they shot an x-ray to confirm, that's this one, that the needle was in the peritoneal space, and then they transfused 100 cc's of O negative blood. They tried that 8 days later and it failed because they hubbed the needle and they couldn't reach anything meaningful. But then they were successful 2 days after that, and then had an induction at 34 weeks and discharged home at 4 weeks of age, doing well at the time. The bottom line says that work was supported in part by the Medical Research Council in New Zealand. And I didn't know if that meant, there was partial financial support or if there was partial ethical support. Like, we think maybe what you were doing was good. I would note that this was work done by a senior research fellow. If you guys want to discover any new and novel treatments, now's the time. So moving to the first cases of fetoscopy in the 1970s and 80s, this is a picture of the first fetoscope being, first published fetoscope being used to find fetal vessels on the placenta and sample the blood. So there was no lasers, no twin-to-twin transfusion syndrome, but they were, trying to assess hemoglobinopathies. And so introduced the fetoscope and then had a needle that would go and puncture the vessel. This is the picture published in the paper of their view of the vessels on the fetal membranes. And this is a true story. I said to myself, that looks like a very grainy picture of Jupiter. So then I Googled grainy picture of Jupiter. And it made me think that I could do the thing that John Oliver does, where he puts up a map and you don't know, like he says, this is Bolivian. It's not really Bolivia. So you should Google John Oliver's Lessons in Geography. It's a very good one. Moving to the first open fetal surgery in the 1980s and 90s. Paper by Dr. Harrison, who's one of kind of the forefathers of fetal surgery, treating a baby with lower urinary tract obstruction, where they knew that they needed to get the urine out of the baby's bladder so that it could get into the amniotic space so that organs could go on to develop. And the presumed way of attempting that was, a laparotomy for the pregnant patient, a big incision on the uterus, and then incisions on the baby's back to pull up the ureters, open up the ureters, stitch them to the skin, and just let the urine drain from the ureters into the amniotic space. This did not work. Unfortunately, the baby died afterwards. But it gave some insight into future directions for fetal surgery. They would later try stitching the bladder to the baby's belly and letting the urine drain out of the bladder. That also did not work. But these were the sorts of ideas that gave way to shunting and amnio infusions that we do use today. In looking through kind of a benchmark history of fetal surgery, sheep were very important for demonstrating feasibility in the 80s, as well as primates for demonstrating maternal safety. Some other highlights, the first ultrasound-guided intrauterine transfusion in 1982, first open repair of CDH in 1986, which unfortunately didn't work, first laser for twins in 1990, first exit in 1995, the first successful open MMC repair at Vanderbilt in 97, and then the MOMS trial, which we'll talk about in fetal trials for CDH. In this time, the kind of governing body of fetal surgery was formed, the International Fetal Medicine and Surgical Society, and they took the time to say, there's probably some ethical questions here. There's certainly some ethical dilemmas in fetal surgery. And so we need to put together criteria that everyone can, agree upon and use. And these are still used today. And so the highlights of those criteria are you need to have an accurate diagnosis and a way of staging so you know who are the right candidates for these procedures. We need to know the natural history of the disease. We don't want to be guessing if this is what's helpful. The paper from New Zealand said in their commentary, maybe this was a baby who would have just survived if we did nothing. And so knowing the natural history is very important. There should be currently no effective or equally effective postnatal therapy, and we should have proven that this was feasible in animal models. And then, equally importantly, these interventions should be undertaken at a multidisciplinary center where you can get lots of good brains together. In addition to forming these criteria, they also formed a lot of conferences with wacky logos. I am a big fan of the placenta surfboard on the left from the conference in Hawaii. I don't really understand the one from Germany. Maybe Dr. Stewart will help. There's the guy at the top with the needle saying 3 times daily, which is, I assume, an NST, but these were just some of the more interesting logos. There's some that were not PC even enough for this crowd, if you want to go Google them. IFMSS gave rise to other networks like the North American Fetal Therapy Network, of which UW has happily become a member. Janine has a question. What's that picture of us on Madison? I'll zoom in. It's Scott holding down the fort. He's got his ultrasound probe and looking for any vessel with peak and Doppler. And so, officially a few years ago, UW and Meriter jointly launched our fetal surgery program through the Fetal Diagnosis and Treatment Center. We had a plan for kind of a slow rollout in 2022, 2023. And kind of much to my surprise, the patients just flooded in, and it didn't quite go according to plan in terms of the slow rollout of patient care. But we've rolled with the punches, and we've learned as we went. And I was at the eye doctor with Peter yesterday, and the pediatric ophthalmologist saw my scrub pants, and she said, "Oh, you work at UW?" And I said, "Yeah." "What are you doing?" "I'm a perinatologist." She said, "Oh, you work in the NICU?" I said, "Oh, kind of. I work with the NICU sometimes." We talked a little bit about fetal surgery, and she said, "Oh yeah, I heard fetal surgery started at UW and then stopped." And so there's still some misinformation about it out there. And so I'm relying on you guys to help, to help educate people. And part of educating people is knowing what we do. So you can go to our beautiful webpage that UW made, and it lists, all the conditions that we treat. I guess that's technically true, even though, we haven't seen a lot of the stuff on there. And so I'm going to focus on the things that we, do most frequently. And we're going to kind of touch on these all, very briefly, and then talk about the future. So twin-to-twin transfusion syndrome, the reason that we, get referrals, the most, this is one of the most common complications of monochorionic pregnancies, affecting 10 to 15% of those pregnancies. And 25% of patients who have TTTS go on to need intervention. Without intervention, we think that advanced stage disease, so stage 2 or 3 or higher, has anywhere from a 70 to 100% perinatal mortality rate. And so, knowing that the natural history of this progressive disease is bad, we frequently offer intervention. This is diagnosed largely with ultrasound. And so if you're out in the world in the future and you do an ultrasound for twins and you see a one twin who's saran wrapped up against the placenta and the uterine wall, you should be worried about twin-to-twin transfusion syndrome and evaluate the need for intervention. The cause of this is pathologic anastomoses on the placental surface, which lead to one twin being preferentially perfused and the other not. This is staged by the traditionally by the Quintero staging model, which you can see here, stages 1 through 5. When I was an undergraduate student at the University of Miami, I did a shadowing thing, and I was just randomly assigned to go into an OR at University of Miami Hospital, Jackson Hospital. And the room I was assigned to was Ruben Quintero, and I didn't know at the time, 20 years ago, that I was walking into. I think I walked into the room without a hat on accident, and I had hair back then, so it was a big no-no. But this is the Quintero staging system, which is kind of largely being replaced by the Cincinnati staging system, which uses a lot of the same early stages, but then relies heavily on fetal echocardiography in order to assess the cardiac function of both twins, with one of the most common reasons for intervention being cardiomyopathy or decreased cardiac function of the recipient twin as they go into this high volume heart failure state. Preoperative ultrasound is used to map the placenta to see where the membranes are, and then to guide us through the fetoscopic intervention. And so we place our 1.9 millimeter fetoscope in, we identify what we presume to be pathologic vessels on the placental surface, and then we use laser photocoagulation in order to occlude those vessels. These are some fetal toes from a case here, which they don't have any medical utility, but it's a cute picture. Using dye to assess the vessel anastomoses is becoming more and more popular. This is not a picture from UW, but I'll show one later. So if you deliver monochorionic twins here at Meriter who've had laser ablation, letting us know about the placenta is helpful, because then we can send it to our pathologist who can do these vessel studies to see if there are still connections between the vessels. Nowadays, laser photocoagulation is the standard of care for twin-to-twin transfusion syndrome. That was proven in 2 trials, Eurofetus and then a similar NIH trial, which showed that if you compared laser to what used to be the standard of care, serial amnioreduction of the recipient sac, you had a statistically significant increase in at least one survivor, as well as a longer latency period of patients staying pregnant. Here at UW, I think one of the biggest things that we do in order to have good outcomes is aggressive tocolysis. This is the Infusino protocol that Scott made for choosing which tocolytic therapy to use. And you can see it's very detail oriented, as is Scott. Thank you, Scott, for the protocol. And thank you to everyone who's helped to take care of these patients. I know a lot of the residents, although it's not like your primary job to take care of these patients on the antepartum floor, I know you've done that. And so I appreciate the work that you've done, because lasering the vessels doesn't do a lot of good if the patient goes on to deliver the next day. And so keeping them pregnant is kind of where the rubber meets the road of fetal surgery. Moving from twin-to-twin transfusion syndrome to fetal spina bifida repair. Spina bifida is a term that's kind of going out of style. It's being replaced by the more specific term myelomeningocele. This is an ultrasound picture showing a lower lumbar or high sacral myelomeningocele. This is the most frequent form, certainly the most frequent form that we assess for prenatal intervention. These cases are relatively rare, but they are serious, with a 10% rate of perinatal mortality and nearly 100% motor dysfunction, kind of regardless of intervention. The MOMS trial, which was started in the early 2000s, published in 2014, took singleton pregnancies with this myelomeningocele in a specific area that were deemed to be serious based on hindbrain herniation. And assuming they had a normal karyotype and were a certain gestational age and at least 18 years, they were offered prenatal versus postnatal repair. Hindbrain herniation is seen here on ultrasound. This is a popular triage question. Ultrasound with Chiari malformation, the banana sign of the pulled down herniating cerebellum on the left, and the scalloping on the right, and then MRI images showing similar Chiari changes. And so the patients were excluded if they were obese, if they had other anomalies, a short cervix. And the outcomes here were two primary outcomes, one assessed at 12 months of age and one assessed at 30 months of age. The early one was death or shunt placement, and the later one was basically motor function. These cases were all done open, so laparotomy for the pregnant patient, hysterotomy on the uterus, repair of the neural tube defect by the pediatric neurosurgeon. And the trial was actually stopped early because it was very apparent that the prenatal intervention was better than the postnatal intervention. As you can see here, there was a lower incidence of the primary outcome, which was death or shunt placement in the prenatal surgery group, and higher motor scores at 30 months of age. And so offering in utero myelomeningocele repair is now the standard of care. Here's some pictures from UW repairs. This is the first one we did, which just based on the baby's position, we were able to make our incision about where you would make a C-section incision. And then the patient actually, stayed for a while and then went back to Green Bay, and her physician who delivered her sent a picture of the uterus at time of C-section. You could see it looked like, it was fairly well healed. This was the neonate on day of life 1. And this is a picture of the repair, which is a pretty standard looking repair. I've learned after looking at pictures of these things. And then the patient still sends pictures of the baby about to start walking, is what it sounds like. And UW Health media is all over waiting for this baby to take its first steps, because they want to do another story about the baby when she takes her first steps. Fetoscopic repair is the future. So these are not pictures from us, obviously, but these are pictures of fetoscopic repair. And so the pregnant patient still gets a laparotomy to expose the uterus. And then the uterus is drained of essentially all of its fluid. It's insufflated with CO2 gas. And so that's what you're seeing here, is the uterus puffed up with CO2 gas. And then fetoscopes, or essentially laparoscopic ports, placed into the uterus, and then the defect repaired laparoscopically or fetoscopically. This has the obvious advantage that there's no big hysterotomy, so then patients are not required to go on and have C-sections in that pregnancy or future pregnancies. Case series from Baylor and Cincinnati show that the vaginal delivery rate approaches the kind of national average, usually around 60%. So it's not a guarantee, but it's much higher than 0% of those patients who have open MMC repair. And so I believe this to be the future, and hopefully the future here at UW. Lower urinary tract obstruction, or LUDO, used to be my least favorite diagnosis to work with, but quickly rising in the ranks. This is typically diagnosed on ultrasound when you see a large bladder, like you can see on the left. with the traditional keyhole sign of proximal urethral dilation. And then, as you can also see, there's a lot of fluid in the bladder, but there's no fluid around the baby in the uterus. Oftentimes we'll also see signs of obstructive uropathy with dilated kidneys there. We counsel these patients in a multidisciplinary way with myself, with NICU, with pediatric urology, with pediatric nephrology, that we expect that this lower urinary tract obstruction to cause issues in 3 main organ systems. One in the bladder, typically caused by posterior urethral valves, and so the bladder can hypertrophy, and it's very common to have postnatal dysfunction of the bladder. 2 is the kidneys. This often leads to obstructive uropathy and can lead to fetal renal failure. And then, most importantly, in my opinion, the lungs. Without amniotic fluid getting out of the bladder for the fetus to drink, the lungs don't develop normally, and so pulmonary hypoplasia, pulmonary hypertension are common. And in certain kind of realms of fetal renal failure have been considered to be lethal. In order to assess, we'll typically do a vesicocystosis, where you can see a needle going through the uterine wall into the baby's bladder. We drain the urine in the bladder, and then we send it to the lab to assess, basically how well are the kidneys functioning. If the electrolytes in the urine tell us that the kidneys appear to be functioning well and there's a good prognosis, then the standard therapy is to place a shunt, a vesicoamniotic shunt, which you can see placed here graphically.
Sorry, I cooked the heck out of it. It's like brown as can be, but I cooked it on higher temperature, so I will cook it on lower temp.
Ludo is it's controversial. And so for a good prognosis, if you think the kidneys are going to keep working and the bladder is going to keep filling, we place a shunt in order just to drain that fluid out of the bladder to, basically function like a urethra. Our kind of future plans for this would be to do fetal cystoscopy, wherein we can actually place a cystoscope into the bladder and potentially ablate the posterior urethral valves or place a stent out through the penis, as this is a condition that typically affects male fetuses. It gets a little more dicey when the prognosis of the urine electrolytes are bad. This is a story that gained a lot of press. A U.S. representative from Washington State, Jamie Herrera Butler, and she tells the story. She went to her MFM scan at 20 weeks, and they saw no fluid in a big bladder, and no kidneys, so presumed bilateral renal agenesis, which is not exactly what we're talking about with Ludo. And, as she tells the story, she was handed a brochure and said, go have an abortion. And she said, I don't want an abortion. I want to see what I can do for my fetus. And so she, kind of sought out alternative therapies, and she went on to have, I think, only 1 amnio infusion. But, her contention was, if the issue is that there's no fluid, can we just put fluid in from the outside and see if that helps, the baby to grow? No one knows the exact details of her story, but the baby was delivered at, in the late preterm period, and was on dialysis for a few years, and then got a transplanted kidney from the husband, and is doing well. And so, it kind of gave rise to the question of, should we be thinking about these serial amnio infusions? And so the RAF trial, the renal and hydramnios fetal therapy trial, was started. The first arm of the RAF trial was for just that sort of patient, a fetus with no kidneys, which has been long considered to be a lethal diagnosis. And they showed that we can do serial amnio infusions on those babies with no kidneys. We can get the fluid in routinely. I think that one patient had 32 infusions in one pregnancy. Preterm labor rates are high, but they were able to get pulmonary survivors, so they were able to get babies who could get out of the delivery room, make it out of the delivery room. But the trial was actually stopped early, as you can see there. The bilateral renal agenesis arm was stopped early because the outcomes were so poor for those babies after they were born. Not having kidneys is, obviously bad for all the reasons we discussed, but they found a high rate of seizures in those babies. They found a high rate of hypertensive disorders in those babies. And so not having kidneys, there was a slight workaround in terms of the amnio infusions for, minimal lung growth, but there was no obvious workaround for, how to provide those children with, kind of a meaningful quality of life. There is another arm of the RAF trial, which is looking at fetal renal failure. So Ludo, like we talked about, and multicystic dysplastic kidneys. And this arm of the trial is going much better. And they've already told us there's a second trial plan, the RAF2 trial, where they will, continue to give these serial amnio infusions, and they're going to potentially offer amnio ports, which is another way to get the fluid in. And you know, my presumption is that UW will go on to not necessarily be in the trial, although we will offer to be in the trial, but to provide these amnio infusions. And so we've done a series of cases like this. This is some pictures from one of our patients this year. You can see no fluid around this kiddo, and then some signs of obstructive uropathy with dilated kidney tissue. And this is a baby who wound up kind of intentionally, kind of unintentionally receiving 6 amnio infusions over the course of the pregnancy, and then delivered and never needed to be intubated. It was on CPAP for a few days. We presumed that the prognosis of these kidneys were bad, and that was accurate. It was a baby who had very poor renal function when it came out, got a peritoneal dialysis catheter, and has since been discharged home on peritoneal dialysis with the plan for that, for that transplant at 2 years of age, assuming that everything goes well and the baby continues to grow as planned. And so more to come here on the Ludo field. Exit procedures or ex utero intrapartum treatment. Exit procedure, I think you're probably all aware of now because you've heard about them a lot over the last few years. But it's kind of a modified C-section with basically placental bypass, where we deliver the baby's head and typically one arm. The head is delivered so that we can establish an airway, and the arm is delivered in order to give medications to the baby. This is done for a number of reasons. Retromicromathia, it's things like Pierre-Robin sequence, which you can see on ultrasound, with the ultrasound image on the left showing effectively no jaw and normal on the right. And then MRI, same thing, effectively no jaw and normal on the right. For chaos or congenital high airway obstruction sequence, which, there's a physical break in the upper airway, which leads to a number of problems and is not compatible with life unless you have, other advanced metrics. And then fetal head and neck masses, those are, probably the most common indication that we've had here at UW. This is a baby, I think referred by Molly Lepic. We saw a, large cystic multiseptated mass early on. We followed throughout pregnancy with serial ultrasounds, MRIs. We did a 3D rendering of this mass in order to plan operative intervention. And then the thought was that if this kiddo, delivered, that the NICU would have a hard time, anyone would have a hard time establishing an airway in the first several minutes before, hypoxemia set in. And so we went to the OR in a very multidisciplinary effort. We performed an exit procedure, and then pediatric ENT used a rigid bronchoscope in order to get, past the obstruction into the airway and place a tube. And then the baby had the mass resected and did well, went home, a few weeks later. CDH is not something I thought about a lot as a OB resident, I'll just be honest, and not really as an MFM fellow either. It's, it always felt like it was more of a postnatal issue to me than it was a prenatal one. But my thoughts on that are rapidly changing. And so this is an ultrasound image from our unit just 2 weeks ago, kind of the classic presentation when you're at the level of the heart, which you can see on the right side of the image. And then you see something else big and cystic in the chest, you presume it to be the stomach. And so this is the classic picture of a left-sided congenital diaphragmatic hernia, wherein the stomach and some of the intestines have herniated into the left side of the chest, and they've displaced the heart to the right. This is, a very serious pathology in the sense that if you have all of this other contents filling your chest, your lungs will not grow appropriately. And so once again, pulmonary hypoplasia and pulmonary hypertension are the big, big issues, the big killers of these babies after they're born. The way that you kind of grade this and, talk about prognosis is through LHR, the lung to head ratio. So you assuming that it's a left-sided CDH, you would go to the right side, you look at the right lung, and you measure the right lung, and then you divide that measurement of the right lung by the head circumference, and that gives you an LHR. More commonly nowadays than LHR, we're using the observed to expected ratio of LHR. And depending on what paper you read, these numbers, these percentages might be a little bit different, but basically they're broken down into 3 categories of severe, moderate, and mild. So the less observed contralateral lung that you see, the more severe you presume these cases to be. And for the most severe, certainly for an O to E of less than 25%, fetal or fetoscopic endoluminal tracheal occlusion has become, I wouldn't say necessarily the standard of care, but this is still, an area of much research. It's been published on now by a number of groups. And it's something that we've done, at UW twice so far. And so we use the same sort of fetoscope that we would for the twin-to-twin surgery. But instead of looking at the placenta, we're essentially trying to intubate the baby. So fetoscope into the baby's mouth, into the baby's trachea. And then we place this balloon. It's a vascular balloon used for stenting, iliac vessels and that sort of thing. And then we leave the balloon inside for ideally 4 to 6 weeks. By leaving the balloon inside the trachea, we're blocking off efflux of fluid out of the lungs. And so the lungs fill with this fluid that, hopefully stents them open and has a lot of vasoactive substances in it that encourage the lungs to grow. And you might be saying, well, what happens if this baby comes out with this balloon lodged in its airway? And now you're thinking like a neonatologist or a pediatric ENT, because that's the really scary stuff. And we've learned through trials and tribulations that places a lot of strain on the kind of working groups here at UW. And so as we move forward with our CDH care and with our potential fetal care, that's one of the primary things that we're working on is how to best care for these babies, because you can't deliver with that balloon in place. There's three ways, three kind of typically considered ways to get the balloons out. In the most ideal world, you would go back 4 to 6 weeks later, the patient never having contracted, and you would do the same procedure, but you would pull the balloon out instead of putting it in. The second way is by puncturing the balloon with a needle. So, ideally while the baby's still on the inside, needle through the pregnant patient's belly and uterus into the needle to pop it. Or if the baby precipitously delivers, you can put the needle right through the baby's anterior neck and pop the balloon. And the third is with an exit procedure so that you're giving oxygen through the placenta while you get the balloon out. We've done the latter two here at UW. This is a picture of a balloon being removed via an exit procedure, and you can actually see the balloon on the screen just below the baby's cords there as it's being fetched by the pediatric ENT. And we have successfully deflated one balloon with the needle-based approach and got on the cover of this IR journal by doing so. You might say, like, that's a lot of trouble to put this pregnant patient through it and to put our hospital system through. And you're right. There's an obstetrician, an engineer, OB/engineer in France who, upon hearing all of this said there certainly has to be an easier way, a safer way of doing this. And so he developed a new balloon called the Smart TO balloon. And it has a little ball bearing in it, a little metal ball bearing. And so when the metal ball bearing is exposed to a magnet, it vibrates and pops the balloon. And so you don't have to do any of these invasive things. You might say, well, how do you get a magnet strong enough? We have a video from his paper about how you get a magnet strong enough. He talked about, inventing this balloon by basically, he started with a condom and a ball bearing and some duct tape. This is him in the blue shirt there. And then he tried it in a sheep, and he took an anesthetized sheep and walked it around the MRI machine, and then a monkey, and then eventually a pregnant patient. And you can see this is a real life pregnant patient. And the only known way so far to expose the balloon to enough magnetic force is to walk all the way around the MRI machine with your belly touching it the whole time, because you don't know which way the magnetic polarity is facing. So you have to do the whole 360 circle, which you're going to see her do here, whilst keeping her belly on. And so I know this sounds and looks kind of silly, but this is I think this is the same sort of like innovative thought process that, had people looking through fetoscopes at blood vessels, and had people stitching ureters to the backs of fetuses. And some of the ideas work and some don't. The balloon and the ball bearing are so small that the babies usually either spit it out into the amniotic fluid or swallow it. They're teeny tiny. Excellent question. The NICU doctors still don't love that answer. But so that in Belgium, they've placed this balloon in 48 patients, 48, actual live human patients, and they've had 100% success rate with deflating it with the MRI machine. They've had no, issues of like the balloon is still occluding the airway when they go to intubate. And so this may be the future. You know, for our cases at UW, this is the most recent, the one that made the cover of the IR journal. This is a baby who had a abysmal prognosis based on third trimester imaging. That's the baby Tegan up there in the top right. They just sent the Christmas card a couple weeks ago. And you know, she's home and doing well now on room air. And so you know, you can't take one cute baby and say that's, you know, obvious that everything's going to go great if you do this procedure again. But you know, I think it's certainly an area of continued you know, work and research moving forward. And so future endeavors, you know, that's where we stand. Those are our main areas of work in fetal surgery here at UW. Future endeavors, you know, I think obviously the fetoscopic approach to myelomeningocele repair is an important one. I think it will become the standard of care. It's a matter of, you know, making our processes work appropriately here at UW. I was discussing it with one of the MFMs from Boston, and you know, he said that they kind of take a very team-based approach to the suturing because pediatric neurosurgeons, I think, don't traditionally operate laparoscopically, and so it might be, you know, a bit of a learning curve. And so he said in Boston they'll have a pediatric surgeon do some of the stitching, the MFM does some of the stitching, and so this is you know, it'll be a matter of getting our teamwork approaches correct. Fetoscopic ablation of type 2 vasoprevia vessels. So you might say, wait a second, that doesn't make any sense. There's only one baby in there. And you're right, there's only one baby, and it's, you know, presumably a full-term baby. But if you have type 2 vasoprevia with an accessory lobe, there have been now a few case series showing that if you ablate the vessels feeding the accessory lobe, then that lobe will die, and you can go on to have a vaginal delivery and save yourself a C-section.
Wow.
Challenging in comparison to the twin-to-twin cases because the vessels are much bigger when this is done in the third trimester. Fetal balloon valvuloplasty of critical aortic stenosis and hypoplastic left heart syndrome. This is being done in Boston. There's still a lot of work that needs to be done here, but these are babies who, you know, are, you know, sometimes need to be rushed essentially from delivery into the cardiac OR. And so if there's something we can do to palliate that process and improve outcomes, then I would certainly be interested in learning about it. And then prenatal shunting of aqueductal stenosis. And so see if Igor will put a needle into a fetus's brain and get a shunt into this area of obstruction. Because the outcomes for these babies when they have long-term, you know, very, very profound obstructive hydrocephalus, the outcomes are universally bad. And so if there's something we could do to shunt that area open and improve those outcomes, then that would be worthwhile investigating. This has been tried, you know, 30 years ago and did not work, but based on my attendance at the conferences, this is it's a popular idea that's gaining more momentum. And so, you know, in looking at our program in particular, short, medium, and long-term goals, you know, I think it's you know, well known that we went through some leadership transition in the last year. And, you know, in my leadership role, I want our focus to be on communication and team building, because I think that if, you know, we continue to work as a cohesive group, that's going to yield the best outcomes for our patients. And then we need to get back out there and increase our referral network, continue to improve our own surgical techniques, utilize our simulation equipment, and establish a simulation curriculum. And then branch out, you know, into a larger research presence in the region and the country. Work on these advanced techniques like fetoscopic myelin repair, getting our fetal program back up. I'd like to involve the residents more in the future. You know, it's been my own learning curve up until this point, and so I would like the residents to be in there, you know, operating with us as well. And then long term to, you know, have a programmatic way to train residents and fellows in fetal surgery, contribute to new innovative techniques that we don't even know about, and grow our fetal surgery team so that it's, you know, it's bigger. A shameless plug, if you go to HSLC today is the Department of Surgery Research Symposium, and our mono twin placenta is a finalist for the Cool Science Image Contest. So if you go near it and you want to vote, I would encourage you to vote for this awesome looking placenta, which we lasered, and you can see there's no connections between the two cords in the middle. And then the pathologist helped us to dye in these nice, beautiful colors. So that's a shameless plug. If you're in HSLC today, I'll split the cash with you. So like I said, I wanted to end on notes of gratitude. This has been a huge team endeavor. So I'm very grateful to, you know, UW and UniPoint leadership, especially Dr. Ross, who's the CMO of AFCH, to the 3 departments who have supported the inception of the program and continue to support it, OBGYN, surgery, and pediatrics, especially Dr. Hartenbach and her, faith in me. To my own MFM division, who's been, very flexible in allowing me to do this wacky stuff. To the ASOG providers who've cared for these patients when they've been admitted and delivered a number of them. To the MFM fellows who've taken on the brunt of a lot of this, post-op care. To the OB residents who weren't supposed to take on any of that brunt, but I know you've taken on some of that brunt. I thank you. To Carla Griffin and Tracy Kwame, to the entire CPC staff, to our ultrasonographers, especially Kelsey, who's here, hopefully starts to blush. She comes to the OR with us and helps map these, very difficult cases. The Meritor OR staff, especially Steph Barman, Terry Price, and Marcus Baker, they helped to get all of this off the ground. The AFCH OR staff have been very, supportive, especially with weird scheduling requests. OB anesthesiologists, especially Dr. Rock and Whidden, who worked on the protocols for these patients. To the collaborators, especially the NICU and my kind of NICU partner, Dr. Lydia Raitt. To the fetal heart program folks, Dr. Sharda Srinivasan and Ali Kiley, namely, who helped to coordinate care for these patients. To all of our collaborating pediatric providers in surgery, urology, nephrology, neurosurgery, IR, radiology. And really where the brunt of this work falls to the FCCs in clinic, who from step 1 of getting the patients here, to getting them to the OR, to helping with all of their follow-up care. I'm very, very grateful. And especially to the patients and the families that we've helped. I think that it's easy when your work is repetitive. It's easy to forget that being a patient takes a leap of faith. Especially if you're doing something that's dangerous and risky and it's a matter of life and death for your unborn child. I think it takes an enormous leap of faith. And so I'm very grateful to the patients for putting that faith in us. This is a picture from one of the first open milo repairs at Vanderbilt of a 20-week fetus, seemingly grabbing the provider's finger. It's called the Hand of Hope. And so this is not a victory lap, this presentation. This is a State of the Union and hope towards the future that we're just going to continue to do, bigger and brighter things. And so I thank you for your attention. I'm happy to take any questions. I need to do the chat thing. Oh, question.
No, I noticed in the mom's file they excluded the BMI of the 35.
Yeah. So in MOMS 2, they expanded the inclusion criteria. So now everyone's in agreement of a BMI over 50 should be excluded. But 35 to 40 is pretty much already set sail. And then 40 to 50 is a, kind of in the moment discussion and decision. The risks are, one, you have a higher preterm labor risk. You have a huge preterm labor risk by incising a big open, hysterotomy. And then you have a higher preterm labor risk, with a higher BMI. And so that's one of the considerations. And also, you have to be able to get all of the neurosurgical equipment in. And so if you get into a place where you can't, get the right tools in, then making the hysterotomy